Okay, we're back and we're going to talk about embryonic and fetal testing. Okay, so that's going to be testing the embryo and or the fetus. So one of the most common tests that almost every pregnant woman would experience is an ultrasound. With an ultrasound, there is a transducer that bounces sound waves off of whatever structures are below it, and then the computer puts that together into an image that's, the more experienced you are reading the ultrasound, more or less interpretable. It's not uncommon to get an ultrasound approximately 7 weeks after conception, maybe as late as 10 weeks after conception, just to make sure that the fetus is, where it's supposed to be, right? That it's actually implanted in the endometrial layer, that there's only one in there, that the pregnancy that's been confirmed with a pregnancy test is in fact, progressing, has a heartbeat, things like that. Doing it much earlier is kind of not that useful because it's very difficult to find the little tiny itty bitty little embryo that has, barely got a heart and things like that. So they like to wait until it's about 7 weeks after conception. Now, if anybody's ever been pregnant and is listening to this, they might be thinking, wait, why did I not get to go till I was 9 weeks after conception? Actually, you were probably called in 9 weeks gestation, which is actually a different way of measuring pregnancy because the average woman is not exactly sure when conception happened. It's just simpler, much more straightforward, and in general more accurate for doctors to count the first day of the last period as the first day of this pregnancy. And so they're very concerned about when was your last period, because like I told you before, usually the period comes about 2 weeks before the next ovulation if you have a 28-day cycle. But it's a guess, right, that it's not perfect because, as I've told you before, the distance between ovulation and the start of the next period is always 14 days. The distance between the first day of your period and then ovulation is usually 14 days, but if there's going to be variation, that's where it's going to be. So if you have a shorter or longer menstrual cycle, that is not going to be a perfect measure of exactly when conception occurred. So they just go with the last known, really clear thing, and they ask, when was the first day of your last period? And so as far, with the doctor counting like that, it gives the impression that pregnancy lasts 40 weeks when in reality it lasts 38. So I'm going to keep saying, how long since conception. And I just wanted to clarify that if you're ever in a doctor's office and the doctor's talking about numbers that are 2 weeks, 14 days longer than what I'm talking about like biologically, literally, if we knew when conception happened. All right. So usually between the 9th and 12th week, we'll see an ultrasound, usually, like I said, to place the baby, to make sure that it's growing and developing and things like that. And almost every mom gets that test. Now, these other tests are rarer. Chorionic villus sampling is usually going to be conducted between the 8th and 10th week, and only in those cases where they're concerned about, potential chromosomal abnormalities, DNA issues. This might happen in the case of a couple who has, they both come from a population that tends to have a recessive trait, and they're worried that possibly the baby might have 2 of those recessive genes that might be damaging. So, for example, if mom and dad have each been tested and they each have the gene for Tay-Sachs disease, and either one of them displays Tay-Sachs, because they wouldn't be moms and dads if they had, if they have the gene for it and they're carriers, then we would want to maybe test and see if the baby has both genes for that disorder. Or sometimes with sickle cell anemia, they'll want to know the same things. It takes 2 recessive genes for sickle cell anemia. Sometimes people do it with Huntington's disease. If they know that that's in their family and they don't want to pass that on to their offspring, they may want it to be tested for that. There are a lot of things that might necessitate testing the DNA of the baby as it's developing. In the 8th to 10th week, we're talking about, just the very early part of the fetal stage. And what they do is they use an ultrasound to place the placenta. They figure out where the placenta is within the uterus. And then they insert a tube through the cervix, so that opening of the uterus, right? So into the vagina and up through the cervix. So far it shouldn't be hurting mom at this point. Using the ultrasound, they will make sure that the what they call an aspirator, the little tube, will line up with the placenta, and they draw a few cells out of the placenta. Now, if you recall back when I was talking about the placenta in another lecture, the placenta is made up of exclusively the baby's DNA. And so if we are concerned that the baby's DNA contains some kind of abnormality, we can draw cells out of that placenta and analyze them without harming the baby or anything like that, and determine whether the baby actually has the DNA profile that they're concerned about. So generally, this is a reasonably safe procedure, but there is always the risk of triggering, a miscarriage through this test. And so it's not without its risks. You wouldn't want to do it just because. You would want to do it because there's something serious that you're concerned about. Similarly, there's the older version, which is called amniocentesis. This is generally going to be performed in the 24th week or later, because I want to make sure that the fetus is big enough that they can really place where it is and make sure that they don't poke it with this very long needle that has to be inserted into mom's abdomen, through the uterine wall, and into the amniotic sac to draw out some fluid. Again, remember that the amniotic fluid is made up of the baby's DNA. And so they can analyze that DNA and see if the abnormality that they're concerned about is present. So amniocentesis, again, does carry with it some risks of damage to the fetus and or triggering miscarriage. And so it is reserved for very specific circumstances. It's not something that's done just to all moms. So all moms tend to get ultrasounds, usually the 9th to the 12th week. And then usually there's a follow-up ultrasound somewhere around 5 to 6 months gestation. And usually mom and dad are interested in that one because they want to find out whether they're having a boy or a girl. The doctor wants to look at it to look for any signs of any physical problems, any growth problems, any kind of, missing structures, or, what if the heart was not encased in the rib cage? That happens, right? So they can diagnose that ahead of time. Some things can be treated while still in the womb. And so it's a very serious thing for the doctors who are administering it. For the mom and dad, they're oftentimes, just excited to get the second ultrasound, and it, usually ends up completely happy. We're just, seeing that our baby's in there and it's happy and it's developing, but occasionally there is something scary that's in that ultrasound and identified that then can be treated or dealt with. All right, so those are our tests that we have available. Now, speaking of, doing these chromosomal tests and other kinds of things, really brings up the issue of, not all pregnancies are ones that the parents want to carry to full term, right? Sometimes they discover that the baby is carrying a chromosomal abnormality that is inconsistent with life, and so they opt to abort the baby, or they didn't want to be pregnant at all, and so they may want to abort the baby. And so I wanted to talk just a little bit about how it's actually done and what we have available these days, because I think a lot of people talk about abortion without being very educated about how it's done, what's involved, and stuff like that. So I wanted to give you sort of the very specific information. So the classic old-fashioned version of an abortion is what's called a surgical abortion. And it sounds like different than what's really done because there's no knife involved in a surgical abortion. What happens is you either get a vacuum aspiration or what's called dilation and evacuation. With the vacuum aspiration, usually if it's early enough, just the first couple of weeks after conception, up to I think about 6 weeks, you can have the vacuum aspiration, and usually the full contents of the uterus will come out all together, and it'll be a simple procedure as far as potential harm for mom. Dilation and evacuation is much more common in moms who are 6 weeks or more pregnant at the time of the abortion, and there is much more extensive placenta engagement and things like that might require her cervix to be dilated, and then sort of a cauterizing sort of removal of the placenta and other things that might be embedded in the endometrial layer. So these are sort of the older time kind of classical ways that abortions have historically been conducted, and they're still available for later term situations. But much more common these days is what's known as a medical abortion. In the U.S., we call it Mifeprex. Over in Europe, they call it RU486, and it's a prescription set of pills that is taken to induce an abortion. And so, as we all recall, when when a woman is pregnant, there's a bunch of progesterone that's free floating around to protect that pregnancy and keep it intact. And so the way that mifeprex works is that it blocks the receptors for progesterone so that the lining of the uterus will shed. So the way that it's administered is that first there's 600 milligrams of mifepristone, which is the thing that blocks the progesterone. It also softens and dilates the cervix to get it ready to, as if in the same way that it would before a period. The endometrial lining is going to start to thin and shed in response to the mifepristone. 2 days later, then you follow up with a 400 milligram dose of misoprostol, and that's what's going to encourage the uterine contractions that will cause the contents to be expelled. So 2 weeks later after that, after all of this is over with, then the woman needs to go to the doctor and have a checkup to make sure that the pregnancy is no longer intact, that she's recovering healthily, and that everything's fine. The FDA has approved the use of mifeprex for up to 49 days after conception. It's 97% effective if used within that window. Some doctors prescribe it a little longer because it turns out that it's pretty effective even after those 49 days, but it's 97% effective if you do it within basically the first 7 weeks of pregnancy. So it's less invasive. It's easier to recover from than the surgical styles. So when women can make decisions earlier on, then they have this as an option rather than having to do a surgical style of abortion. Now, I wanted to talk a little bit about some of our stereotypes that we might have about what kinds of women tend to have abortions and when they do it. So first off, this one is when. So if we look at this pie chart, right, we have a third of women having their abortion when they are 7 weeks or less pregnant. So they would be candidates for the mifeprex style. Then we have, basically, let's say 30% of women who have their abortion in the 7th or 8th week. Then we have 25, almost 26% who have their abortion between the 9th and the 12th weeks after conception. And then we have these much smaller numbers of women who have abortions after that. When Roe v. Wade was first passed, the definition of the endpoint for when abortions would be legal was defined as the point of quickening, when the woman could feel the baby moving. And then they updated that to be the point of viability, when the baby could actually live outside the mom's womb. If it were to be removed through C-section, then that, if it could survive without the mom, then it was entitled to survive within the mom, was the view. And so historically, that cutoff point was pretty late, right? Because back in 1972, babies couldn't really live outside their moms. Fetuses couldn't live outside their moms till they were probably 30 weeks. We've dropped that point of viability down significantly, and that has raised a lot of questions about how long abortion should be legal. I just really wanted to emphasize that 21 plus weeks, which is 21 weeks is still below the point of viability. I think the youngest surviving fetus was born at like 22 weeks and a couple of days. So we're still below the point of viability when we look at the 21 weeks or older. It's only 1.2% of abortions that are performed at that point. And this chart is only telling us that an abortion occurred. It's not telling us why the abortion occurred. Those abortions that occur later in pregnancy are very much more likely to be attributable to actual physical harm rather than psychological harm. When Roe v. Wade was passed, they said that you could have abortions to protect the life of the mom, the health of the mom, sorry. And pretty quickly, it was expanded from the physical health of the mom to the psychological health of the mom. And early abortions oftentimes have been what we like to call sort of no question kinds of abortions, psychological or physical. It didn't really matter. Early abortions are usually less controversial to people. But these later term abortions have been a hot button issue for at least 20 years. And people have really been talking about them like they're very common for one thing, and that they're very commonly done just for a whim. And in actuality, most abortions that occur at past 12 weeks are done for physical reasons, more likely than for psychological reasons. All right, now how about abortions by maternal age? So a lot of people hold the stereotype that abortions are something that teenagers use, and that they maybe didn't know how to prevent the pregnancy, and or they were tricked, or they were raped, or something, and they were young and didn't know any better, or things like that. And what the statistics show us is that there are women of all ages who use abortion for a variety of reasons when they are faced with an unplanned pregnancy, or a lot of other reasons. Remember I mentioned that miscarriage is a lot more common for women who are over 35. Well, also much more common among women over 35 are chromosomal abnormalities that would be harmful to the developing fetus, and that might actually harm mom's physical health. And so women who are 35 to 44, we may be seeing an increase in abortions that are due to chromosomal abnormalities, or physical malformations, or mom's health might be at risk. Sometimes moms will develop what's called preeclampsia, where they have hypertension, that the cure for their hypertension is to end the pregnancy. And mom might have a stroke, or mom might have a heart attack if she were to continue this pregnancy. So when we look at these ages, we need to take into consideration that our stereotypes about what motivates an abortion may be faulty, that it may not be that a person is having an abortion because they just don't want to have a baby. They might be doing it for a lot of different reasons. Now, the most common age to have abortions is the 20s, right? Between 20 and 29, we're looking at 33% plus 24%, right? So nearly 60% of abortions occur during that very young adulthood, when fertility is at its peak, and that this might be more in line with what we think about as far as women who this is not the appropriate time, the father is not staying nearby, this is not going to work. That may account for a higher proportion of abortions among this age group than we would see perhaps in the 30s and 40s. So there's nuances to these statistics that need to be taken into consideration, and so the less we can stereotype, the better we are in understanding this actual, these procedures. Here we have abortion rates broken down by racial group, and we just have white, Hispanic, and Black. And what they've done is corrected, the different, because, 62% of women are white, 14% are Hispanic, 12% are Black. So they've kind of corrected for the disparities in the raw numbers of women in each group by saying per 1,000 women, and they're looking at really those reproductive years, 15 to 44. And so let's start with the unintended pregnancy bars. So we see that 35% of white women have an unintended pregnancy, 78% of Hispanic, and 98% of Blacks. I don't mean percent, sorry, it was maybe 9.8% of Black women, 7.8% of Hispanic women, and 3.5% of white women, because this is per 1,000, not per 100. So sorry, I went off into my own thoughts for a second there. So 35 white women per 1,000, 78 Hispanic women per 1,000, and 98 Black women per 1,000 experience an unintended pregnancy. And then when we look at the abortion rates, we see 11 white women per 1,000 have an abortion, 28 Hispanic women per 1,000 have an abortion, and 50 Black women per 1,000 have an abortion. So while we have much higher rates of unintended pregnancy among Hispanics and Blacks. We see more of a stair-stepping of abortion rates among whites, Hispanics, and Blacks. And so what this suggests is, well, it really kind of indicates, okay, you got 35 unintended pregnancies among per 1,000 white women, and 11 of those seem to end in abortion. So you've got about a third. And then you've got 78 among Hispanics, and then 28 ending in abortion. Again, about a third. And then about half of Black unintended pregnancies ending in abortion. So it's more of a stair-stepping when you look at the rates of abortion than it is on the unintended pregnancy columns. But you definitely see that among Blacks, it's more common than among Hispanics or whites to resolve an unintended pregnancy with abortion. So just some racial differences and probably some cultural things going on and circumstantial things that are going on that make abortion more or less of a choice for a woman based on her ethnic group. So things to keep in mind, right? That there are different pressures on women of different kinds that may cause them to need or to resort to abortion more often than women of other kinds or other circumstances. So things to keep in mind. So in 2011, the U.S. abortion rate reached its lowest level since 1973, and it's actually been going down since 2011, in fact. So fewer women are having abortions, even though in another context, I'll show you the pregnancy rate. The pregnancy rate is dropping also. So, we're probably still having similar proportions of pregnancies ending in abortions, but overall pregnancy, unintended pregnancy is down, and overall abortions are going down, which is good news because that implies that either women are using more reliable birth control or abstaining longer or other things that are maybe preventing them from getting pregnant, or that if they are getting pregnant, then they're seeing the opportunity to keep their baby or give their baby up for adoption or something like that. So there's sort of like different things that might be happening that are tied to these abortion rate changes. All right, well, I think that's enough on that. I think we'll come back in the next segment and we'll talk about things that are going on with mom's body as she goes through pregnancy.